Oh, great pleasure to be here. When I came into this world, I said I have to give only love. Pyar, pyar, pyar. But it became so frequent, it became PR. Okay, so I think my time is about robotic beyond TME. Okay, good. Oh, okay, this is the department of GI surgery, so you require a lot of team and assistance when you want to operate. So when you think about rectal cancer, most of the things we are talking about TME and without the envelope. But you have cancers with, despite all these departments, so it goes beyond the boundary. So you can have tumors going anteriorly, seminal, vesical, prostate, bladder. In females, it will be uterus. Laterally, it will involve the hypogastric nerves, lumbosacral trunk. Posteriorly, you have the sacrum and the inferior compartment. So anything beyond that, of course, will be called beyond TME. And doing this extensive surgery, does it improve outcome? There is a group called PelVex, which looks at outcome. And for primary cancer, outcomes can be as good as 50 to 60%. For recurrent, again, it is turning out to be good, 40 to 50%. For other malignancies also, 3-year survival is up to 50%. So you have to operate. But before you operate, obviously you need judgment, you need a team, and you have an MDT to discuss what is the plan of surgery. You don't operate without a plan. And what is the component of this? The component for this are the lateral compartment or lateral pelvic node dissection. And this is combining excision of the rectum, the uterus, the bladder. And then you have the reconstruction thing, urinary conduit and perineal reconstruction. So that's the end of the procedure. You have a specimen here, VY reconstruction, Bakri balloon, and you have the two conduits there. You can do open or MIS, but MIS has got better views. We'll see. Urinary reconstruction, you do Brickers or Wallace. You can do intra or extracorporeal technique. Most important thing before you go on for MIS thing, I will do MIS because you can see better. You should have good outcomes. We have one of the studies where you have the benchmarking of pelvic exentration with the Australian unit, and our outcomes are quite acceptable. Evolution of MIS exentration, you cannot do MIS exentration if you have done many. So your outcomes improve forever. So if you've done more than 1,000 TMEs, the outcomes get better after every 100 TMEs. Then you start with the lateral compartment. So you do some case reports and videos and see how things go. And then you analyze your learning curve. The idea is not doing the dissection. The idea is to get all your nodes out and not having recurrence for 2 months. And the learning curve for MIS lateral pelvic node dissection is 19 cases. Then you talk about doing exentrations, laparoscopic or robotic. And we were doing 10:1 laparoscopy to robotic. So we started with laparoscopy and the outcomes were quite okay. So I'll just start with few videos and we'll see how things go. So first we think about addressing the lateral compartment. So with lateral node dissection, what you normally do is, I think you've heard of a lot of theoretical talks now, so we can talk about this. When you do a lateral compartment, you first define the ureter and then define the ureter and vesicohypogastric fascia. Next, you find out the obliterated umbilical artery and you follow it up to the origin of internal iliac artery. I think we have a lot of surgical oncologists here, so like Somu must have done thousands of this dissections or something. You define the medial and lateral paravesical space. This is a good disease. Okay, this is not a bad disease. You don't have large nodes. All pelvic node dissections look very good when there are not bad nodes. When there are bad ones, it becomes oozy. So once you define the plane, there are a lot of vascular variation. In this case, the superior vesical artery is coming quite high from the origin of obliterated umbilical artery. So, okay, there are variations there. Once you do that, then you tackle the external iliac nodes. And that is quite standard. But unlike the gynae thing, most of the recurrences are in the internal iliac compartment, so we don't tackle the external iliac. Unlike the gynae, you're operating after radiotherapy or sometime boost or SBRT, so they are more challenging, whereas gynae, these are all staging procedures and you won't have. So a lot of these, when you do this dissection, you may have to do some other technique which I'll show. You preserve the obturator nerve, you see the fork of external and internal iliac and define the obturator nerve. The obturator artery was ligated, I could see in the beginning there. And you just dissect the obturator nerve there, sort of thing. Most important thing now is to follow branches of the internal iliac. With the left side, the position is pretty good, so you can see all the branches of internal iliac artery. And you can ligate them. This is only lateral node dissection. So normally if you're doing an exentration, then we'll do that again. The other thing that you have to see in all these procedures is to see the lumbosacral trunk as well, we'll show. So here we're taking out all the components there. So just for anatomy, you have the hypogastric nerve there, which you can see, and then you can see all the branches of internal iliac artery going there. Variations of internal iliac are quite a few. And most important thing is lumbosacral trunk. You need to define this. If you want to do sacrectomy, you have to preserve this organ or knock it off. Suppose if someone has SBRT or you're going to do external iliac node dissection, this has actually been shown well by Somashekar in many of his videos before. The best is to go behind the external iliac vessels, even if you have second surgery there, because there are no branches behind the external iliac vessels. So you can go behind and see the obturator nerve from there, and then that part of the operation is okay. We do a lot of lateral node dissections for melanoma where external iliac nodes need to be removed. You also sometimes do it for NET as well. And because you see, everyone is trying to improve outcomes. So our radiation oncologist wants to give SBRT for them or SIB therapy as well. They do it with long course and sometimes with short course. And dissecting this, and if you want to do an exentration to find an origin of internal iliac artery, is very difficult. So it will totally be plastered there. And sometimes you do it something like Basanti, Haatho mein chabuk and Hotto pe galia. So you send all the observers out, short-sighted residents, and then you can manage somehow, because the most thing is you don't want any morbidity there. And then you can see external iliac. So that is one of the ways. So when you do this, you can define the bifurcation of external iliac, internal iliac artery, and for exenterations, you're going to ligate them at the root. This is the same thing. Unfortunately, I can't forward it slightly more. But the time duration should be okay. And the thing is to look at the bifurcation. If you can't find internal iliac, find the obliterated, go from here and there. If one side is not working, you can go from top, behind, up, or bottom. The thing is, if you have anterior margin positive, or it's coming close there, then you can do a beyond TME for seminal vesicle excision. For extended resection, you take a peritoneal cut. That's the first thing if you want to beyond you. Take a cut along the external iliac vessel and taking the peritoneal flap there. Then you go up to the vas deferens there. And you have to realize when you want to do this, the ureter will go just below the vas. So if you can define that, that's the first step for extended dissection. So you trace the ureter in the vas and follow up to there. And based on that, then you can do an anterior plane there. So this judgment whether you're going to take the seminal vesicle out is very important, because anterior margin threatened ones are really difficult to make out. So you should have made a plan. So sometimes the base of seminal vesicle is involved and you may have to take the Denon-Villers fascia out. Or sometimes the whole seminal vesicle is involved. So here, now we're defining the ureters. Here the anterior catheter already gone. With this you can do with laparoscopy or robotic. Sometimes the control is better with robotic. And if the disease was going laterally, I think after you preserve the ureter, you can actually cut S2, 3, 4, and the hypogastric nerves as well. Here it is not too bad, so we will define the seminal vesicle anteriorly on both sides. Sometimes in young patients, it's better to ask them to ejaculate the night before, otherwise some of these seminal vesicles are really quite huge. And if you think your Denon-Villers fascia is also involved, then don't take a cut of Denon-Villers fascia from the top end. If you're planning to do an APR, you can take en bloc some chunk of prostate along with Denon-Villers from bottom. Boss thoda ruk gaya kya? Haan, theek hai. Then I think this is what the gynae oncologists do quite a lot. If you have, this is only for surgeons in the crowd. So there, suppose if you're going to do a posterior exentration, so sometimes it's you do the same thing there. You define the ureter and you define the obliterated umbilical artery. The extended cut is still there. If someone gets bored in the crowd, just let me know. We have another 20 slides. We can just dwell on that. But I think you heard a lot of literature now, so maybe you can see something. So first thing is to define the ureter, then you see the obliterated and the origin. So the first branch of from the obliterated umbilical will be the uterine artery, and you trace it there. So I think radiation makes it slightly more tricky, and actually personally I don't like short course because there's a large dose of radiation which causes the levator to fuse with the low rectum, and sometimes it takes a lot more time to do it as well. I think the posterior plane is also involved, so here you'll cut the hypogastric nerve and probably go into the presacral fascia and excise that. I think in the morning they showed a upper rectal cancer with a presacral node there. Those are very interesting ones because some of them respond very well and go away. But those ones which are persistent, sometimes you have to define both the iliac veins and take all the pre-sacral nodes out along with the specimen. Oh, I don't know where I've gone. So we have dissected posteriorly. I think this is supralevator exentration, so you'll mobilize the whole thing and you'll define the other side as well. I'm not sure whether did we take the uterine on one side or... So again, you'll follow the uterine artery, take the uterine artery, go anteriorly and do it. See here you have defined the uterine artery. You don't have to go, the disease is not too bad on this side, so you probably, and then you trace the ureter. I think this part after radiotherapy, dissecting in the ureteric tunnel is slightly more tricky. But the advantage of this is, unlike cervical cancer, most of the endoluminal disease, the disease won't be coming into the vagina and you're not worried about spillage. We all know for cervical cancers, I think most people are not doing MIS now because of the chances of spillage. And after this, what we do is cut the anterior wall and posterior wall. The posterior cut, you can tailor it, and then you dissection along the rectovaginal septum till you reach the pelvic floor. And you define the TME and you cut it, and that is the easiest part, and you can see the anatomy is quite well seen. You probably do the same thing with open, but probably you can see better with MIS sort of thing. And then you close the vagina and then you staple the anastomosis. Okay, so with everything should be en bloc. I think the next one is TP with an intracorporeal conduit. So if you have anterior tumors which are involving the seminal vesicles, prostate, then you probably need an exentration. If you have only prostate, then you can do a prostate shape. You can do a variant as well. If only the prostate is involved, you cut at the neck of the bladder and do bladder sparing exentration. So here, I'm not sure what conduit I'm going to do. For an old patient, if you don't want to save time or doesn't go well, you preserve the left colic and you can use the sigmoid as a conduit, or you can do a wet colostomy. Here you make an anterior cut, you cut the vas deferens, you follow posteriorly. The lateral cut is done as well. Next, this further cut depends on how bad the tumor is going, sort of thing. So again, like you did for lateral node dissection, that is the basic for exentration, you will define the ureter there. I normally cut the ureter in the beginning because if you straighten it out or thing, the vascularity becomes default. So I cut the ureter and mobilize it. You should always plane a layer of tissue along the ureter. And then you do the lateral node dissection and define the origin of internal iliac artery. You see in the lumbosacral trunk as well. And now you lift the obliterated and you see the root of internal iliac artery which is ligated. Internal iliac vein you can ligate at the root, or you can only take the branches going into the bladder. Next, I think taking the bladder down is quite easy. For total pelvic exentration, you don't have to take the DVC from the top end. Next, you form an intracorporeal conduit, which is okay to do. You can also join the ureters to the conduit here itself. I think for chubby patients, probably better to do an intracorporeal conduit. For this ureteric anastomosis, we call the urologist. I think the rest of it is done by us because for the simple reason there is not enough workforce for them or for us to do it. But I think operating for exentrations is the easiest part of the job. The difficult part is looking after complications, which are quite common. If you excise the rectum, the bladder, lateral node, and perineum, so you get complication rates of 40 to 50%, urinary leaks are 10%, stricture rate at 10%. You need good follow-up for them. Then after doing all this, if your bowel drops into the pelvis and you have empty pelvis and you go back and again with the conduit, it's a problem as well. So we put a Bakri balloon to prevent it. The other thing I think which is coming out is, this is viviplasty we do, is about bleeding. I think Anil hadn't shown enough, so we will see. We're doing a lateral node dissection, and while doing it, if you have bleeding, I think the best thing to do is get your assistant to put a gauze piece there and keep his hand on, And then with your two hands, so your anatomy is defined. So you take proximal and distal control. So you've taken the internal iliac artery here because the vision is there. Here you're taking above the superior gluteal artery, the origin of internal iliac. And then you will take the bladder thing off. So I think there are no data for RCT from this. You should have data about, so we had to do our own study. When we finished 60 MIS exentration, we compared with our open thing. And we found oncological outcomes were okay. Obviously, the blood loss was less. And because the vision is so good, we do that. We doubled our numbers to 120 MIS exentration. And again, the oncological outcomes were acceptable. They won't be very good because they are Signet and PDAC and young patients, and they have a lot of problems. We probably have the largest series of MIS extended TME, and that was published in colorectal disease, 752 or so. And we looked at outcomes comparing them. So if you look at them, PDAC Signet are really very high. And oncological outcomes otherwise, they were quite okay. Local recurrences for extended TME was acceptable. So about 400 exentrations so far, almost 50% are done MIS sort of thing. Robotic abuse now is increasing. But still, there were not enough numbers for robotic exentration. So there was a multicentric study from Jim Kham from Portsmouth to see if it can be done, because the next thing is to go for trials, whether you can do robotic or versus open exentration. And people in Europe are not keen on any more laparoscopic procedures, so we can't do that. So if you want to do a multicentric trial, it has to be robotic. And in this multicentric experience, the conversion rate was 4.8%, R0 resection of 8 to 2.1%. Fortunately, we have the second robot arriving in TMS, so I think the number should increase, and maybe a lot of people in this room can contribute to trials as well. These are complications of urinary reconstruction, perineal wound dehiscence. I think only surgical oncology is vulvoplasty, empty pelvis. So you identify problems in this meeting and try to fix them. If you have recurrences, you cannot see have recurrences. You try to improve on your technique and see how things go. Patient selection is key. So if you have someone who's got signet ring cancer, lateral pelvic node, a single metastasis, and then probably the outcome for this is not very good. So if you have 4 and more of these criteria, patient is going to have recurrence within 6 months or die. Judgment is key. So I think all in all, exentration improves outcome. This can also be with MIS, with decreased blood loss. You need training and compartment things. So we have 4 fellows in our department, and if they stay for a year, they can operate as good as me, I can tell you that. Morbidity is high despite MIS, and the best thing is judgment. Avoid futile resection. There is a lot of work to be done on quality of life and patient-related outcomes. Thank you. Okay, I think well.
The last slide is the most important slide. The lady behind the man to make successful. Don't miss that.
I know. While we end patient suffering, we cause suffering to family.
So regarding the role of MIS in exenterations, do you think that laparoscopy and robotic are equally okay, or you want robotics?
I think learning curve for robotic is slightly on the lesser side. Means I do a lot more laparoscopy, so I'm okay with it.
Once you're through with the curve, in exentration comes with the multi-organ resection. So is it advantage for robotics over laparoscopy?
I think once you standardize the procedure for anything, then it is the same, I think. But the only thing is, in laparoscopy, you are in charge. You need a really good assistant for robotic if you have bleeding. For laparoscopy, you can manage.
Reconstruction part also is robotic.
Reconstruction is pretty good.
So thank you very much, sir. If there are no more doubts.
Thank you.